How many of you have had a transplant? Oh gosh. How many of you have heard transplant in a doctor's office? That might be something you need to be thinking about. So some, and some not. So I'll just hit some of the highlights. We have a booth over here where some of the educational materials are. But first off, thank you for coming. Thank you for coming, and I'm happy to be here. So you can tell by my colored gray hair that I've been transplanting since 1984. So I have about 30 years of experience at the University of Iowa and then at the University of Minnesota. A couple of years ago, I moved over to the National Marrow Donor Program, and I have a big interest in survivorship. That how do you live following a transplant, and how do you live following therapy for your underlying disease? I'm going to fold some of these things in today. I'm going to tell you what I've seen in transplant over the last 30 years, the changes that have taken place, some of the advances that are improving outcomes, and I really want to tell you about a lot of resources for you, whether or not you're thinking about a transplant, you're not thinking about a transplant, but have leukemia, myeloma. We've got a lot of resources for you. So you heard a lot about allogeneic transplant, but there's two types of transplants, right? There's autologous and allogeneic. Those are big words. So we call them autologous, it means self, using your own cells for a transplant. And allogeneic, you just heard from Dr. Sai, is getting somebody else's cells. So let's just look at autologous transplant over here. If you're the patient, you can get the cells you need from a transplant from your bone marrow, the old-fashioned way kind of back here, or also from the bloodstream, peripheral blood stem cells. And people come to me and say, what is this bone marrow transplant or blood transplant? You just got to get those cells to grow, right? The great-great-grandparents, the stem cells, and we can get them out of the bone marrow. I was standing in an operating room in the early 1990s. No, take that back. Maybe 1980s, and we were hearing about this drug that patients could take, and you could get the stem cells to come out in the bloodstream. That was phenomenal. It changed the world. Don't you think, Pat? Pat? Yeah, it did. So we could have patients that had cancer in their bone marrow, and now we could get cells that come out in the bloodstream and use those for a transplant. It really revolutionized the world, and I'll show you a little bit about that. And you've heard quite a bit now about allogeneic transplant, and again, you can take cells from a donor, either from the bone marrow or the blood, and you've heard a bit about umbilical cord blood transplant. So my gosh, look at this. So this is data from the research arm of the Be the Match, and this shows you the number of transplant recipients in the United States since way back when. I did my first transplant in 1984. And this is autologous. So using your own cells. This is the blue mark. Hang with me. Can anyone think what that little blimp is on the blue that shows that blimp up at around 1995 to 2000? I've got to quit doing that. The mouse doesn't work very well, I apologize. I'm getting a little confused. Do you know what that was? It was breast cancer. Do you remember when they were thinking about the transplant might be able to cure breast cancer, and unfortunately then the trials that were done did not show that. So that was that blimp up. Autologous transplant now, we're looking at about 14,000 of being performed in the United States every year. And the green line, steadily increasing, is the allogeneic, using somebody else's stem cells. So now, what do we do an allogeneic transplant for? This is using someone else's stem cells. The most common type of donor, as you just heard from Dr. Sai, is actually an unrelated transplant. Take a look at that. That's that orange line climbing up. The next is a matched sibling, and that's because only about a third of people will have a perfect matched sibling. You have a 1 out of 4 chance of each sibling being a match to you. The green line, that other relative, shows you the climb in haploidentical transplants. You've heard about that, coming along and really helping patients who don't have another source of a transplant. And then the little teal blue line on the bottom, that's the number of umbilical cord blood transplants that are done each year in the United States. You've heard a bit about a haplotransplant. Again, this is a half match, a mom, a dad, a half match sibling, or a child. And so you're a half match for your parents. And so that means a sibling, instead of having a 1 out of 4 chance of being a perfect match, now has a chance of 1 out of 2. All right, so much more likely to have a sibling that might be able to help you. So let's just focus on this slide a little bit. There have been a lot of advances made throughout the transplant process. Before transplant, you receive a type of therapy to help reduce the number of cancer cells in your body and get your body ready for a transplant. Almost all autologous transplants now are done as outpatients. You don't even need to be admitted to the hospital. Or if you are, you might be in the hospital for that first week and discharged the day after, instead of being in the hospital for 28 days. Because we can now really help support a patient, and most patients with an autologous transplant will have their cells start growing back in engraftment in about 10 days or so. So we can manage that as an outpatient as long as you stay nearby the clinic. You've heard that with all the types of donors, almost everyone has a donor now. So that's, if you need an allogeneic transplant, it's not a reason to not have a transplant. We can find a donor for you. Back when I was transplanting in the 1980s, a patient with acute leukemia, we would go to transplant in 3rd remission, way along the course of the disease, because we had so many bad side effects that could occur, right? The first thing is not to harm a patient. But now we know that the best time to go to a transplant is early in the disease, in 1st remission. Get there before the cells become resistant. So that has changed dramatically. We now have what are called reduced intensity conditioning regimens. So for that first week before transplant day, we can reduce the dose, we can reduce chemotherapy, if a little bit of radiation. We can make it much safer for older patients and those with health problems to undergo a transplant. You heard a little bit about preventing graft versus host disease if you have cells from someone else. There's been drugs that have been shown in addition to the cyclophosphamide that may be beneficial to patients. We know how to prevent complications now, much better supportive care. One of these is that there's a virus called cytomegalovirus, a big word, CMV, that in the 1980s, in order to get an investigational drug, you had to prove a patient had that disease with a sample or a culture that might take days to grow, and then ask the FDA to get that on a compassionate use. Now we have methodology, we have methods to know when that CMV is starting to grow, we have drugs to help prevent it, we have specialized drugs, there's a new one coming on the market that treats it effectively, so that in the old days, that virus, people died all the time from that virus, and now it's pretty darn uncommon. So there's just been a lot of advances that have been made. We also have post-transplant therapies. So the biggest problem with an auto transplant using your own cells is that the disease may come back. And that, in the past, has been about 50% of the time. But now we can use drugs after the transplant to kind of keep it away. And it's just made a huge difference in a variety of diseases, including lymphomas, multiple myelomas, and now we're starting to see that. You heard earlier about these special targeted therapies in leukemia, like that FLT3. Those things have big things that I can't spell, and hopefully you can say them, to help keep cancer away. So it's just really been an exciting time in transplant that leads to better outcomes for our patients. Now, we always laugh within the transplant field that we keep increasing the age that a patient might be able to transplant, because as transplanters are getting older and we want to have options, right? But it's because of what I just showed you in the past slide that we can offer transplant to older patients. So until 2004, I would get a call from a doctor and say, I have a patient who's 67 with acute leukemia. And as soon as I heard 67, what did I say? They're too old, but no more. We did a survey this past year looking at transplant centers, and the vast majority don't have an upper age limit anymore, because we can get patients safely through transplant. So we can sort out those problems that you might have early on and counsel you and help you decide if it's something that's too risky for you to undertake. But the other issues may be more important than your actual age. So age is not a reason not to undergo a transplant. And to just show you, this is the trends in getting your own cells for a transplant by age. And this is back from 2000 on the left to 2015 on the right. What's the biggest growing area? Orange, okay? And what is that? 70 years and older, all right? So that's the, right up here we've got a candidate. So you're not told to have a transplant, it's just the other health issues. As we age, we have other health issues that your doctors will want to attend to. And that's why if a transplant might be something you might need, it's important to get to the transplant center early on, because we can work with your doctors to help make you more fit for a transplant. So that's fine, that's autologous, using your own cells, and that's the safest type of transplants we do, because you don't have to worry about the graft versus host disease. But look at this. This is allogeneic, using someone else's cells. And look at that orange starting to creep in. I mean, this is the toughest type of transplants to do. So look at the green. That's been rising steadily, 60 to 69 years of age. And now we're seeing 70 years and older for allogeneic transplant. Well, what do you do a transplant for? Well, the most common reason to have an allogeneic transplant is acute leukemia. And the most common one in adults is acute myeloid leukemia. That's the third one from the left. The most common reason to have an auto transplant using your own cells is multiple myeloma or a plasma cell disorder. They're kind of cousins to each other. But what's really interesting is that we're being able to expand transplant as potentially curative options for other patients. And one of the ones we're paying a lot of attention to lately is sickle cell disease. Okay? So it doesn't have to be cancer. There are patients that have problems with their bone marrow that doesn't work, that have problems with how the red cells grow. And these new conditioning regimens are making it possible to get new healthy cells in there, replace white cells, red cells, and platelets, and help other people. So keep your eyes out. It's just not for malignancies, it's for all kinds of blood disorders. For autologous transplant, the most patients that undergo this are the blue line, and that's the multiple myeloma. Almost 8,000 patients a year, United States, undergo a transplant. It's an indication for within the year of diagnosis. And the second most common are the lymphomas, okay, about 5,000 per year. This is using someone else's cells, allogeneic. And the most common, as I told you, is that green bar. And the reason that some of these are growing and going up is that AML is not a young person's disease, right? Okay, most patients are diagnosed in their 60s. When I started transplanting, the upper age limit was around 40, all right? But now as we can offer transplant to older patients, more patients with AML can undergo transplant, and the number of transplants from a donor is rising for AML, okay? I'm going to give a little bit of advertisement here so that we think about Be the Match is only here to help you if you're having an allogeneic transplant, but that's not true. If you're having a sibling transplant, a haploidentical transplant, a parent or child transplant, we have a variety of services to help you, that we can provide the same type of benefits for related donors as for an unrelated donor if Be the Match is involved in helping do that stem cell collection. And we have a variety of patient support programs and grants in terms of travel and support that they're also eligible for. So that's really helpful when people have a sibling or parent that lives in California and you're in Chicago, and they can donate there instead of having to travel, and we'll help support all of that. And I want to tell you a little bit about other things that we can do, whether or not you're having a transplant or not, because you're all here because you have an interest in blood cancers today. And so we have a support system, and it's called a patient support system. We'll help you during transplant, but we have a huge number of educational materials in multiple myeloma, acute lymphoma, acute myeloid leukemia, ALL, any of these diseases we have patient educational materials for. You can call with any kind of question that you have, and if our staff doesn't know, guess who you're going to get? You're going to get me, and I will provide an answer for you. And we have translated resources in 11 language support in 100 languages. We can help you learn about transplant, donor searches, questions about finances, insurance. We help write appeal letters if there's a problems. We have a Peer Connect program, so you can talk with someone that has the same kind of disease you have. We have a variety of webinars, so please go on and take a look. This is a young woman who had a transplant actually for sickle cell disease. We have a lot of caregiver resources. It's tough to be a caregiver for someone you love, and it takes a huge amount of time and energy and emotional support. So we have a variety of short videos that don't take very long to take a look at. We have Patient Connect Facebook page if you like being online. So many patients have not had a transplant but are thinking about it. We have a variety of information on all the diseases that you can access. And this is something new starting July 1st. And this is a Jason Carter clinical trial program. And so Jason lost his life to acute lymphoid leukemia. And his parents have been meeting with us and gave a sizable donation to help support a clinical trial program. In recognition that many patients are struggling to find clinical trials, and maybe they've exhausted some of the resources at their local center, but there's a lot of trials ongoing throughout the country, right? So this is written in language that you can understand. You can simply, there will be a phone number that you can just call. And Scott will take your call. And we have a nurse who's been at the University of Minnesota working in the clinical trials program there for many years, who will take your call. And we will do the searching for you. So you can call and say, here's about my disease, and I'm looking for a clinical study, what's out there. And right now we're focusing on, because of Jason, his need was acute lymphoid leukemia. We're focusing on the acute leukemias right now that will be rolled out July 1st. The intent is over the next 6 months that we will roll out for all diseases. And this isn't transplant. This is phase 1, phase 2, the early trials for people's diseases and responding. We'll also include the phase 3 trials as well. But if you're wanting to know if there's a trial that might be able to assist you, you just simply will need to give a call, and we'll do the work for you. We'll also work with your physician, provide you the information and the links. So I mentioned we have a variety of resources for you and your care team. They're on print, they're online, we have mobile apps. These are guidelines and information. If you just what you want to say about multiple myeloma, we have information for you in language you can understand. Lymphoma, anything that you would like to hear about. We also have a toolkit for you and for your doctor about thinking about if a transplant is necessary, when would the right time to be to refer. As I mentioned when I started, I have a big interest in helping patients live healthy lives. And so we have toolkits for you and for your physicians, kind of a checklist of what you need to be watching for and what kind of health matters that you need to be aware of for after transplant. So with that, I hopefully have caught us up a little bit, and I'm going to be around here all day too, and really would love to talk with each and every one of you. So thank you.